This is our 32nd annual Women in Medicine Breakfast, and this is all the work of the Women's Caucus. And I think 32 years speaks a lot to the perseverance and to the incredible group of women that keep this going, and of course to the staff that keeps this going, Martha and Melissa, and we're very appreciative. So if the people that are here from our caucus, if you could just please stand so people can see who you are. I have names and I know who you are, but I'm not going to say those names out. So that's some of them. That is some of them. We also have student representatives, either student or residents that come to the caucus. I think you're back there? Yes? The students that are on the Women's Caucus? No? Well, we'll get you later. Okay. All right. I'm not kidding. We'll get you later. So this is a group that has been putting on programs, and if you get a chance, if you could take a look at the back where we have a poster there with the programs that have been the most recent. We didn't have room to paper this room with all 32 presentations, but there's some very good information. There's some nice little things for you to have from Physicians Insurance, which I'm going to get to in just a moment. But please take a look and see all the program that we've done. It's really a wonderful group. If you're interested in joining, you're more than welcome. We don't need a whole lot, and but we do some good things. So thank you again for coming. So I want to acknowledge the support that we have had for years from Physician Insurance, which used to be called PIAM, P-I-A-M. And this is the insurance company through the Massachusetts Medical Society. So right now I'm going to introduce our speaker. We are thrilled to have Dr. Tara, right? I said that right, not Tara. I said Tara, sorry. Dr. Tara Kumaraswamy. She started her medical training here in Worcester at UMass Medical School, and then went on to her residency also here in OBGYN. And she then went to pursue a fellowship at the University of Illinois in Chicago in complex family planning. During her fellowship, she had an opportunity to work abroad in India and Bangladesh, and she worked with International Planned Parenthood. She completed a master's in public health, and since coming back to UMass 11 years ago, she started a family planning service that provides complex contraceptive care alongside miscarriage management and abortion care for the patients of Central Massachusetts. We are thrilled that she's able to talk to us today. This was something that she came up with this title. I really like this. And just remember that an election is coming up on November 6th. And if ever there was a reason to vote, this is it. So we are going to hear about, as you can see, the Dobbs.
Thank you so much. Do we think this is working now?
I think it might be a course.
Yeah.
It's on.
Hello. No. Hello, everyone. I'm Tara Kumaraswamy. Thank you for that lovely introduction and for having me here today. I actually didn't come up with the title. Some genius here came up with the title. So
Jen Yates, right?
Dr. Jen Yates is a genius, so there we go. I am going to be focusing on several different things, but we will come to this throughout. So I do not have any disclosures, but I do want to share that I'm going to share parts of my story. So that's me with my first child. I myself had the opportunity to have sex education in high school. I was able to access birth control throughout my life. I got to plan when I had my children. So unlike many people in the United States, I had access to all those things that enabled me to make the life that I wanted for myself. Not everyone has that, and so I think it's really important that we think about the privilege that we have and what we are able to experience in our lives due to that privilege. And so this is a passion for me, family planning, and so that is what we're talking about today. We're going to talk about the history of abortion because it's quite interesting, actually. So we'll get started right there. So in the mid-19th century, abortion was actually legal in all the states until quickening. Quickening was somewhere between 4 and 6 months, where you might feel something moving inside of you. These days, it's similar for our patients. It might be gas, it might be a baby, they're not quite sure. And so it's very similar back then, but then laws started popping up. The first one was actually in Connecticut, and they made a legislature regarding abortion, and it made it illegal to use poisons to end a pregnancy. Then, as the century progressed, most of the medical professionals were males, and most of the abortion providers were females. The rich were able to access abortion, kind of like today. And so it became a bit of a money struggle between the professional medical folks and the abortion providers. And so it became more and more restricted as time went on. So by 1900, every single state had laws against abortion. And I'm sure many people are familiar with Roe v. Wade. This was a case that was brought, and the woman named Roe was actually, her name was Norma. She was a 21-year-old woman who lived in Texas. Excuse me, sorry. And she was going to have her third child. She wanted to access abortion, but was unable to, because in Texas, the only way to have an abortion is if your life was at risk at that time. And so she actually met up with the lawyers, and they thought she would be a good case to bring forward. And so in 1973, the Supreme Court ruled 7-2 that there was a constitutional and fundamental right to privacy, which included abortion care. The state could not interfere with abortion until the fetus was considered viable. And so that was a win for those that felt like this was something that should be a decision between patients and their providers. It should not be something that was micromanaged in the political world. So I just want to do a general review of abortion, because I know not everyone does this every day like I do. And I'm really happy to see many colleagues out here, people that I trained with, people that I went to medical school with, people that were mentors, people that grew up in the town that I grew up in. So I know that there's a lot of different experiences here, and I just want to review this in case not everyone has this knowledge. So 1 in 4 pregnancy-capable people will have an abortion in their lifetime. Sometimes the data is even as high as 1 in 3. The risk of dying from a first trimester abortion is 0.6 in 100,000. The risk of dying from a full-term pregnancy is 14 times that. And I just want that to sink in, because I think sometimes the rhetoric and the misinformation that is spread to patients is really completely untrue. So why might I have a picture of a colonoscopy? Anybody know? Most people get them.
Risk is higher for colonoscopy.
Yeah, the risk of death is actually higher in a colonoscopy than an abortion. But no one's talking about colonoscopies as an issue. Or, I mean, I think people are talking about them, because they're not public. I know that my mother didn't enjoy having her prep, but it's not the same kind of rhetoric that comes up. And so this is a medical procedure, this is healthcare. And so that's why we're talking about it today. So medication abortion consists of using the medication mifepristone, and yesterday was actually the anniversary. It was approved on September 28th, 2000. So 23 years ago, mifepristone was approved for medication abortion. It was approved because it's safe, it's effective. We use it now up to 11 weeks, which is further than when it was first approved, but we have found it to be safe and effective in 95% of cases at even 11 weeks. So it's been used millions of times, and I'm sure you've heard in the news, and we'll talk about it a little bit more, this has also been brought up as an issue in Texas as well. But right now, we will continue to talk about medication abortion as an option for our patients. And there's also procedural abortion. So we do that in 2 different ways. Manual vacuum aspiration is what is here. That device, it's handheld. You create suction, and you can use it anywhere. So it's wonderful to use around the world. It's wonderful to use in our clinic. It doesn't make any noise. Some people hear that abortions are really loud and scary. This actually makes no noise. We use it in our operating rooms because there's supply chain issues, and we don't have the other equipment sometimes. So this is a really safe way to do an abortion. Those are the instruments that we use. We use a speculum. We use a tenaculum to hold on to the cervix, which can be definitely crampy. This is the cannula that goes into the uterus, and this is how we open the cervix gently. We always provide a cervical block, and in the office, patients receive a cervical block and ibuprofen. In the operating room, they can be put to sleep if that's what they prefer, or receive like the twilight sleep as well. So patients have options when, in many places like Massachusetts, they do have options for how they proceed with an abortion. We use the electric vacuum, which is plugged into the wall, hence the electricity. We use that typically after 9 weeks and into the 2nd trimester as well. There's a great video online. It's from the Guttmacher Institute. Guttmacher is an institute that studies abortion, and they collect data, and then they put it into this YouTube video. If you literally YouTube Guttmacher, who has an abortion, there's 2 parts on who has abortions, and it makes it really interactive and understandable for those of us that maybe don't love all the graphs and data in that format.
Who has abortions in the United States? It's an experience shared by people from all walks of life. In fact, you might already know someone who had or will have an abortion, because about 1 in 4 U.S. women will have an abortion by age 45. Here's what else we know. Among those who get abortions, 75% have low incomes. That's why it's so important that abortion be covered by Medicaid and other insurance. Most people getting abortions are young adults. 60% of abortion patients are in their 20s, while fewer than 4% are under 18. And the majority of abortion patients already have at least 1 child. Regardless of income, age, or whether they're already a parent, everyone seeking an abortion should have access to timely and affordable care. Who has abortions in the United States? People of all races, ethnicities, and religions get abortions. Let's look at the numbers. In the United States, 39% of abortion patients are white, 28% are Black, 25% are Hispanic, and 9% are of another race or ethnicity. When it comes to religion, the data might surprise you. 24% of abortion patients identified as Catholic, 17% described themselves as mainline Protestant, and 13% as evangelical Protestant. 8% identified as having some other affiliation, while 38% had no religious affiliation. No matter their race or religion, everyone seeking an abortion should have access to timely and affordable care. Learn more at guttmacher.org.
We get to Boston when it's hard to get to your Worcester appointment. One patient came to us from an outside hospital, and she had literally been placed kind of on her head because she was bleeding, and there was nothing they could do for her. This was a highly desired pregnancy. She wanted this child with all her heart. She came to us and was literally bleeding out of her vagina. We were able to take her to the operating room because one of my mentors had trained in abortion care, and we were able to remove the pregnancy as a life-saving measure for this patient. The patient is actually an academician, and so wrote papers about the loss of her pregnancy in the workplace. And she comes to see me for her annual exams now. Somehow we got to reunite after my fellowship. And she still talks about it. She has 1 child that she's really happy about, but she is so thankful that we were able to provide that service for her. And she wants people to know that this is something that can be life-saving, that should be accessible. And it's actually the same procedure for a miscarriage or an abortion. So for people to be trained in that, she feels is really important. So I just wanted to share with you a little bit about her. And she's doing really well these days. So here you can see the abortion levels from the time of Roe v. Wade in 1973 to about 2017. So we actually peaked around 1980, and then the numbers started to drop. And does anyone know why that might be? I hear the answer. Contraception. Yes. So access to contraception, options like long-acting reversible contraception really help people. It's also important for patients to be able to decide what option is best for them, because for some people, long-acting reversible contraception is wonderful. For others, it's not the right option for them. But with access to contraception, the abortion rate was declining. It started to go up a little bit around 2020. And so it shows that while it's dropping, there is still a need for abortion care. And so it's important that we provide that as well. So we're going to move on to the current laws in Massachusetts. Raise your hand if you're aware of all the laws in Massachusetts about abortion. Okay, yeah, so that's why this is perfect. All right, so an abortion in Massachusetts is any medical treatment intended to induce the termination of or to terminate a clinically diagnosable pregnancy, except for the purpose of producing a live birth, provided, however, that abortion shall not include providing care related to miscarriage. So that's really helpful, because in many states where abortion is outlawed, there is sometimes confusion about miscarriage, and we'll start talking about that a little bit more as well. In Massachusetts, abortion is legal up to 24 weeks from implantation, so that's actually 26 weeks because of how wonky we do our dating, and it's confusing for us and our patients. Beyond 24 weeks, it is also legal to preserve the life of the patient, to preserve patient's physical or mental health, for lethal fetal anomaly or diagnosis, And that was actually implemented in 2020 with the Roe Act. And so there was a lot of work around the state to implement that law after a patient had to travel out of state for a lethal fetal anomaly. And then most recently in 2022, they passed for grave fetal diagnosis that indicates that the fetus is incompatible with sustained life outside the uterus without extraordinary medical interventions. This probably seems pretty complex, and so most of the time this decision is not being made by one person. It's often being made by like a maternal fetal medicine doctor, so a high-risk obstetrics doctor in connection with the OBGYN and the patient. In Massachusetts, we don't have a waiting period. We actually have a law on the books, but it is not enforced, so there is no waiting period. You might have heard in other states, can you all hear me in the back? Okay. In other states, sometimes patients have to wait 3 days, so they might see a doctor and then have to wait 3 days for an abortion. We do not have that here in Massachusetts. We do still have a law that minors under the age of 16 must have parental consent or judicial bypass. That was also a change made by the Roe Act. It used to be younger than 18, so we gained 2 years for our patients. Some people might say, oh, of course it makes sense. Why wouldn't you tell your parent? Does anyone have any idea why we might not want to tell them? Some of us might not want to tell our parents right now what we're doing. So we know, actually previously in Massachusetts, you had to have both parents' permission. So imagine people that maybe their parents are divorced, foster care system, there's so many different issues. So for minors who are able to talk to their parents and feel comfortable and safe sharing this with their parents, then of course they have their parental support, their parent can sign. And when we see these patients, we always ensure that it's the patient's decision and they have their parent's support. So if their parent wants them to have an abortion and they don't want to have an abortion, we're not doing that abortion because it's the patient's choice. Has anyone heard of judicial bypass? Right. So does that seem like an easy process? I myself have never had to stand before a judge. But if I was 15 years old, having to stand before a judge and decide and explain why I need to have an abortion and have any number of questions asked of me, I think I might be terrified. I myself, at the age of 32, maybe couldn't have explained why I wanted to have a child or not and what it was going to be like, because you don't know till you have your child what it will be like, and each child is different, as I've learned from both of my children. So these patients then have to go before a judge and explain their choices. Thankfully, Planned Parenthood connects patients with a lawyer and an advocate who can then help them with this. And one positive from the pandemic is this is now often done virtually as opposed to in person, which to me seems maybe a little more doable, but still hard to say. And I think these laws are often framed in a way that are saying that this is beneficial for patients to make sure that they have the parental support. But we know that in some circumstances, they could be kicked out of a house, they could be literally physically harmed. And so that is something that we need to just remember. And it's a way of limiting access, and especially for those that have less resources. Now we're going to talk about how these laws around the country impact those in Massachusetts. So since Roe, there were nearly 1,400 restrictions that were brought forward in the United States against abortion. And in the 10 years prior to the fall of Roe, nearly half of those restrictions were brought. So this has been an ongoing battle to undo Roe since the time of Roe v. Wade. And when you look at it, it kind of, you might not notice it because it's across the whole country. You might not notice it if it's outside of your state. But in contrast, there are not thousands of different laws going up trying to protect patients and their access to care. Many of you have probably heard of SB 8 in Texas. So that was Texas taking the lead again and anti-abortion care. In 2021, they basically came up with this idea of vigilante justice for patients seeking abortion. Any individual can sue a patient who obtained an abortion, as well as anyone else who aided or abetted in the abortion care. So that means like potentially your Uber driver, maybe your doctor, maybe the nurse, maybe the volunteer at the clinic. They then reward the suing individual with $10,000 if the suit is successful, as well as having them pay the legal bills for the person suing. So that just sounds insane. And then other states have introduced similar legislation. So this vigilante justice seems kind of insane, but in reality, in Texas, it's quite possible that this could happen for patients and those that support them. So at that time, this heartbeat bill really restricted abortion to earlier than 6 weeks. everybody know they're pregnant at 6 weeks? Does anyone remember their last menstrual period? I know you, sir, yes. But it's really challenging to remember when you last had a period, when you have life happening. And you might not notice symptoms of pregnancy, and this is especially true for certain populations. So many younger individuals might not notice these symptoms, many people who have not had a pregnancy before, and actually many people in their 40s think they're in menopause, but they're pregnant. Yeah. So that always terrifies me as well, as a perimenopausal woman. So unfortunately, last year on June 24th, 2022, the US Supreme Court ruled to revoke the constitutional right to abortion in the case of Dobbs versus Jackson Women's Health Organization. It had been nearly 50 years that Roe had been in place, and they overturned that on that day. Abortion access is now determined on a state-by-state basis, and on that day, there were many trigger laws that had been written in states that were written to go into effect immediately. So abortion access was immediately limited. And it really put the onus on the states to determine what they will do. So I'm now just gonna share something personal. On that day, it was a Friday, like today, I'm usually at Planned Parenthood. I'm teaching our residents how to do abortions. I'm often working with medical students. And I started getting a flurry of texts from former residents, from my husband, and then I knew that this had happened. We had heard of the leak. We'd been preparing for this for years in the abortion community. We were thinking that this could happen. But when it happened, it still felt like a gut punch. But on that day, I still had to go forward and do abortions and provide care for those patients that were there in that moment, even though it felt devastating. And so I think I did post this on social media because we need to continue to be there for our patients. And patients are grateful for the care that we provide. So this is the current state as of September 19th, 2023. This is changing daily, but you can see that there's a pretty big swath across the lower half of the country where abortion is severely restricted. We can see in Massachusetts that we're in the protected area because we still have that parental consent law. We're not in the very protective or most protective area. But you can see that there's a large number of people across the United States that cannot easily access abortion. And as time goes on, it seems to be spreading more and more. And it also seems like, New England is a pretty protected area, except New Hampshire, and many, New Hampshire borders other states where patients can access care. So we're going to talk about what does that mean for our patients. There was a study done in 2019 where there was the question of if abortions in those states that were likely to ban them occurred, what would happen to those patients? So if we looked at 10 women, I'm using women because that's what the study used, 7 would be able to access care outside of a state. Who do we think those people are that can access care outside of a state? Wealthy people, people with connections and things like that. 1 person would find another means to end a pregnancy, and we can imagine what that entails. And 2 would give birth. And so amazingly, there's a doctor, Diana Green Foster, who has been studying this for the last 10 years. So she knew that many studies sought to claim that abortion is detrimental, is harmful, and she wanted to look at what about the patients that aren't able to access abortion and compare them to those that did access abortion. And her study, which is actually a good comparison group, the study found that people that were able to access abortion were doing fine. They didn't have any negative impact on their health. But those that were turned away from abortion care had a substantial impact on their lives. Almost immediately, they had elevated levels of anxiety, stress, lower self-esteem, and being denied that abortion actually led to economic insecurity for the women and their family, as well as a 4-fold increase in the odds that they would have an income fall below the federal poverty level. So this isn't just like a one-time thing that doesn't really mean anything for that woman and her family. It can be detrimental and can cause generational trauma. We also need to talk about maternal mortality. With the lack of access to abortion, maternal mortality will increase by 21%, with rates as high as 33% for Black women. There's already a huge issue with systemic racism in our country across healthcare institutions, and this is just going to further elevate that. We know that states with more abortion restrictions have higher maternal mortality rates. They even polled OBGYNs in the last year to ask, do you think this is affecting maternal mortality? And 2/3 said, of course it is. And I think that number is probably even higher if we talked to people in states that this is affecting them. We talked about this. This is going to most impact low-income people, marginalized racial and ethnic groups, as well as trans folks. Imagine thinking that your only option is Florida, but then you don't want to go to Florida because you might just never be able to leave Florida and you might be imprisoned. It's not just getting your abortion. There's the travel to get your abortion. So abortion costs money. Then you have to travel somewhere. Then you have to find someone to watch your kids. I find that an insurmountable task. And then every other expenditure while you're away. So while some companies were offering to provide payment for the abortion, I don't know, are they truly going to cover all of that? And who wants to tell their boss about this? Some people do, but some people don't, and we should be able to respect that privacy. Additionally, there's these pregnancy-related emergencies, such as ectopic pregnancy, if someone breaks their water, sepsis. In many of these states, the doctors are unsure of when they can act. They have to wait until the patient's belly is full of blood before they can remove that ectopic pregnancy because there is a heartbeat. Someone is literally dying, and that is the only time when we can then remove the pregnancy, and at that time it might be too late. We've all heard horror stories of that, and that is happening across the country because people are afraid for their license. Here's a couple of rules and regulations just to review. HIPAA, we're all familiar with that. One of the things to keep in mind is disclosure necessary to prevent a serious and imminent threat to the health or safety of a person or the public. Abortion is not a threat to the public. The patient gets to decide what's happening. So it is not a HIPAA violation for a patient to have an abortion and not share that information. Protected health information, many groups like the ACOG, which is our national organization, and the American Medical Association says that we do not have to disclose reproductive health care to other entities. And then EMTALA, we have a lot of our emergency medicine colleagues here. Patients have to get stabilized when they present to the emergency department. And so these are just things to consider, but it can be very confusing for patients and providers. So in Massachusetts, we have patients traveling from out of state. I have seen many patients come who have family here, sisters, they've gone to college here, they did training here, and now they're coming back for their abortion. They have connections here, they have a place to stay. They have access to care because they know Massachusetts. A Planned Parenthood study in the last year showed that there was a 37% increase in patients coming from out of state. Oftentimes we see patients, and I work at Planned Parenthood as well, we see patients coming from like the New England area just because it's easier to get in, New Hampshire, Rhode Island. But we also know that even Cape Cod is an abortion desert. Patients have to come off the Cape and often come to Worcester because it's easier than Boston. Bans are being continued to be enacted throughout the country, so we know that the volume is likely to increase, but we are not a border state. I have a colleague who worked in New Mexico at the time of SB 8, and the number of abortions, it was like 4,000 times higher than they had previously experienced, and they were just booking 4 to 8 weeks out, and their staff was just burning out because they were trying so hard and they couldn't imagine sending someone back to Texas without the care. Additionally, there's the issue of education. We have some amazing advocates in our medical school, from our medical students and our nursing students who really want to ensure that abortion is part of the curriculum. And so they advocated and increased that in our medical school curriculum here at UMass Chan. Additionally, residency, it's part of the OBGYN curriculum. It's mandated that residents are trained in abortion. It obviously can't happen in these states where it's illegal. So those residents that chose those programs without knowing that now are losing that access to training, and now we're trying to create collaborations with many of the states to bring their residents to states where it's able to be provided. That's not easy, leaving your home for weeks at a time, impact on the residents at the program where they're coming, and so this is going to impact trainees for quite some time. Additionally, those applicants into the field of OBGYN, the majority of them want to have abortion training, so that's making it harder for those states, for them to get into those states where abortion training is happening. We also have what's called the Ryan program, where we train residents in abortion care, and many of those programs are now located in states where abortion is not provided. So residents chose those programs because of the Ryan program, and now they can't go there. Back on my manual vacuum aspirator page, I had it was from the READY program, which is the family medicine program that provides training for abortion and sexual health. And so that's another great avenue, but similarly, their programs are being affected as well. Additionally, patients come to us with questions, and I know I'm getting low on time, so I'm going to speed it up. Patients come to us with questions about contraception. They are afraid of getting pregnant. They're afraid of traveling out of state to visit their family in South Carolina because they won't be able to access care if something were to happen in their pregnancy. We've seen an increase in number of patients asking for permanent sterilization, folks that have never been pregnant. We're happy to provide that for them, but the number has really increased. Additionally, patients are afraid that they're going to lose access to long-acting reversible contraception, that they came in really high numbers asking for Mirena, Paragard, Nexplanon, so that they wouldn't have to have the fear of getting pregnant or not accessing contraception because they're worried that that is what's going to be taken away next. Some questions that patients often raise is, how much does an abortion cost? In Massachusetts, Mass Health covers abortion. Most of us don't check whether our private insurance is going to cover an abortion until we need it. So that is an issue for many of our patients. At Planned Parenthood, without insurance coverage, both a medication abortion and a surgical abortion before 12 weeks is $850. There are funds that help. The Jane Fund is one of the Central Massachusetts funds that provides funding for our patients that need it. In the hospital, abortions are tens of thousands of dollars. So that is not, like, I don't get paid tens of thousands of dollars for this. This is like the hospital fee and all the other fees associated with it. So for our patients that can't be seen at Planned Parenthood because they might have a medical condition, or they desire general anesthesia, or they're too far along to be seen at Planned Parenthood but we can see them at UMass, it is astronomical. I just wanted to speak briefly that medication abortion is used about 53% of the time across the country. Many people don't know if it's legal in their state because there has been so much brought up about medication abortion. This is a case that's currently before the Fifth Circuit and has led to our state stockpiling mifepristone because we're concerned that perhaps we won't have access to it in the future, that they will be forced to stop making it. So thankfully, right now, medication abortion is legal in Massachusetts. Mifepristone is available in Massachusetts. We also use mifepristone for miscarriage management. It actually makes it more likely that the patient who takes the mifepristone and then the misoprostol will be able to pass their pregnancy if they choose medical management of their miscarriage. This is also something that we use on labor and delivery. If someone has a demise, it helps get them ready for delivery faster. So this is something that is used in many different areas of reproductive health. Self-managed abortion is another option for many patients. They might access these medications through the internet, through different online resources. Some people choose to use misoprostol alone. These are extremely safe methods. When you obtain it online, it is mifepristone. But other methods such as toxic substances, trauma, those obviously are not safe. In herbal treatments, we really don't have much data on that, so we can't really speak to that. One of the most common questions patients ask is, can I get pregnant again after an abortion? And the answer is yes. This does not harm, as long as you have a safe abortion in a safe place, this does not impact your ability to get pregnant in the future or carry a pregnancy. If anyone's interested in adding mifepristone, any primary care docs out there want to use mifepristone, there's a training that is for the next 12 months. It's really a well-supported initiative. So if you're interested in that, Liz Janiak, who's at Harvard, is one of the coordinators of that. It is an awesome opportunity to really expand access to mifepristone. You can also write about it. You can do op-eds. You can write letters to your politicians. These titles were taken from folks that are here in Worcester that are advocating for their patients. This obviously doesn't just affect the world of OBGYN. This affects people across all medical specialties. I was thinking, oh, the one that bizarrely popped in my head was like, maybe the NICU. I'm like, no, duh, of course. It affects the NICU because those patients are going to be born sometimes with really difficult circumstances if they're not able to access abortion. Reproductive Equity Now is another advocacy organization. Disclaimer, I am on the board. But they have now expanded to include Connecticut and New Hampshire, and they're the ones that helped really pass the Roe Act and provide protections. So there's also protections in Massachusetts that passed in 2022, right after the fall of Roe, to protect providers, pharmacists, patients, in case we are providing care for others from outside of state or for the care that we provide in the state. So that's also important. If anybody has any legal questions, they can utilize this legal hotline where pro bono lawyers are providing their services pro bono. You can also use this guide to find abortion care in Massachusetts, as well as those centers that are fake pregnancy centers is what we call them, that pretend to provide abortion care but do not. So sometimes that can be really misleading for patients, and so you can direct them to the right options. And this is a picture that was provided by one of these wonderful individuals here, and their friend named their boat after the fall of Roe because it was very striking for them. So Roe v. Wade. Any questions that I can answer?